Hello, everyone, to another episode of the podcast series of Bate. Bate is the outreach initiative brought to you by the Rohini Nilekani Center for Brain and Mind at NCPS. It is my absolute pleasure to invite Dr. Pratima Murthy, our guest for today's episode. Pratima is former director and senior professor of psychiatry at the National Institute of Mental Health and Neurosciences, or NIMHANS as we all know it, in Bangalore. She has over 3.5 decades of experience in the field of addiction and mental health, something we will cover today. She's an alumnus of Bangalore Medical College, completed her diploma and MD in psychological medicine from NIMHANS, and another diploma in psychological medicine from the University of Manchester in the United Kingdom. She is also a fellow of the Royal College of Physicians in Glasgow in the UK. In addition, she has an honorary doctorate from the Satya Sai University of Health Sciences and the YSR University of Health Sciences. As director of NIMHANS, she has undertaken many innovations in patient care, training, and research, including rights-based initiatives for persons with mental illness, provided leadership to many other initiatives such as the NIMAHNS, the Karnataka Brain Health Initiative, and the National Mental Health Survey too, and served as an expert to the WHO. As a specialist in the field of addiction, Pratima has made seminal contributions in clinical care, publishing more than 400 articles, but also in training, research, policy, and her work has been recognized with several prestigious awards. I welcome you, Pratima, to today's podcast with us. Thank you for being here.
Thank you, Shreya, for having me on this podcast.
We'll start a bit today with, your life and career in psychiatry and your journey through this path and where you are today. So could you walk us through that journey a little bit, from medical student to choosing psychiatry as your field of education, and then adding research onto it along with clinical care, which is already a huge workload in itself. And if you could take us through that journey and tell us what motivated and fueled you.
Right. So when you do medicine, I think there are usually two decisions ahead of you. One is whether to follow the medical stream or the surgical stream. I think fairly early in my studentship, I was fascinated with medicine, with what made people ill, how do you recognize symptoms of illness, what do you do to get them better, and of course, the chronic illnesses also fascinated me because it meant, keeping in contact with patients to make sure they stayed well, not just got well, but stayed well. And therefore, the choices ahead of me were the medical disciplines. And of course, NIMHANS at that time, as now was very well known as a place which offered an MD in psychiatry. So in addition, of course, to writing several other entrance examinations, I also wrote the diploma in psychiatry at NIMHANS, and fortuitously I just got in. Now psychiatry is something that was an alien discipline to all of us at that time. This was 30 years ago, and one didn't really know very much about psychiatry. More than 30 years ago, actually, looking at it. I mean, it was in the mid-1980s that I had to make this decision. It was in 1985 that I got into my diploma in psychiatry at NIMHANS. So the human mind is something very curious to everyone. Everybody wants to understand the human mind. And therefore, I thought, I probably entered the profession more out of curiosity than anything else. But that curiosity kind of quickly changed into a fascination about how you combine medicine and mind. And that stayed on, and I think in about 3 to 6 months, I got hooked to psychiatry. And within psychiatry, possibly because addiction was something that linked the body, the mind, the brain, all of it together, it particularly fascinated me. So my dissertation in MD was in the area of addiction. And automatically, therefore, the draw was to have a career in addiction. And for a moment, I haven't regretted it. Because one of the things I've always felt is that people who are addicted, you take out the addiction from them or help them to deal with the addiction. They're some of the most fascinating people, the best people that I've actually been able to work with.
Right. Amazing. And I can imagine you've had a long association with NIMHANS, right from being a student there up to really being the director. Not many people can claim to have had that entire journey. And could you elaborate for our audience then what you've seen, how you've seen NIMHANS change over the years? And, it is the premier neuropsychiatric hospital of our country, leads investigations in research as well as in clinical care. How has its focus sort of changed in the last years, if it has changed at all? And how does it lead research in that field?
So I think one of the things I have noticed is that it has been stable over time. And I think that stability, that dedication,
Right.
an institution is made of people. I mean, you can't have, it's not just bricks and mortar,
Yeah.
it's the people who are the soul of the institution. And therefore, one thing that has remained constant is the dedication to patient care and keeping the patient at the center of all activities. That is something that has remained a constant, right from the doctors to the nurses to all the attendants who really care for the patients. So, and I think that's something that people appreciate. And it's truly a temple for care.
It is.
Honestly so. So that's something that has only grown with more and more people coming in. It's something of a challenge in many institutions because, that same philosophy of care, that dedication very often dilutes.
Yeah.
And nicely for NIMHANS, it has stayed the same. But in addition to that, I think there's been a lot more impetus to training over the last couple of decades. From starting with just about 3 courses when NIMHANS started, there are more than 100 courses which are running now. From postgraduate courses, one has also diversified into undergraduate training programs which are linked to the allied health sciences. So that's another change. And as far as research is concerned, I think we've really come a long way. Because I think the opportunities for research have increased. People have moved out of their comfort zone, which is predominantly clinical care, to trying and answering questions about clinical care. So I think that is the fascinating part of NIMHANS, that a lot of the research is focused around answering questions, which can then transform into improving patient care and then taking care not just to the bedside but also to the community.
Exactly.
So that's another fascinating thing. And I think the other thing that has changed is the advent of technology. And technology has allowed us to do so many things, right? From genetics to imaging to using technology for treatment and care.
Yeah.
It's just been fascinating, and I think that's happened. Now, in terms of my own gaze, from my studentship to, as you said, being at the helm of affairs, I think it's been actually a love affair with NIMHANS. Because I think the more you kind of work in an institution, the more you really enjoy working in that institution, and you grow with the institution. Yeah. So it's not just the institution growing, but I've also personally grown with the institution.
Right. Yeah, it has been a fascinating journey, I'm sure. And being at the helm of affairs, what do you think both the approach of the government and the society has been towards mental health? I mean, we have come a long way, I presume, but even then we do deal with taboos related to mental health, and we know that it is not often as spoken about as, let's say, physical health in a sense. Has there been a shift, and what kind has it been, and how long do we still have to go?
So I think there's been a huge shift in terms of really being sensitive to mental disorders across time. And I think that shift is really influenced by a variety of things. So for example, I mean, if you take a lot of firsts in mental health, they happened at NIMHANS.
Right.
For example, the establishment of a model for the district mental health program, the establishment of the national mental health program, the training of doctors.
Right.
Trying to integrate mental health care into general health care. That whole model came from NIMHANS, as did more recently the NIMAHNS model.
Exactly.
So I think what has happened is that over time, the government has looked to institutions, particularly NIMHANS, to really pave the way to, to really see what direction it takes. And NIMHANS is one of those few institutions which, although we are a specialized mental health and neuroscience institution, we've always engaged with the community. We've always engaged with NGOs, with people working at the grassroots to try and take mental health care to the grassroots. And therein, for example, some of the early work in community included working with faith healers, included working with the grassroots NGOs, and trying to get them to identify mental health disorders. So I think in that process, of course, stigma is something very, very universal. It's not just confined to our country. Everywhere there is stigma around mental health care. So I think increasing the conversations around mental health care, integrating mental health with the neurosciences has also been a very important step towards addressing and reducing that stigma. And I think in more recent years, especially post-COVID, there has been a great emphasis on mental health disorders, and that along with the National Mental Health Survey, which actually showed up numbers of persons with mental disorders, I think there's much more of an acceptance of mental health, recognizing mental health disorders, but I still think we have a very long way to go. Because I think that part of integrating mental health care with general health care needs to be much stronger, so that every healthcare professional, every doctor, every specialist, in addition to looking at physical disorders, also looks at the mental health component. And that bidirectionality, now we call it multimorbidity. The fact that no illness occurs alone, it always co-occurs with other illnesses, especially the chronic disorders.
Right.
And mental health is certainly a component of that.
Right. Yeah. I'm glad you brought up talking about mental health care along with general health, because that was going to be one of my next questions. We just had the budget announcements of 2026 where mental health care was given quite a bit of prominence. What are your thoughts on the fact that mental health services are being proposed to be streamlined through primary care centers, as well as more, budgetary announcements also alluded to the fact that there would be more apex institutions as well. So how do we streamline healthcare through both those channels? What are your thoughts on those?
So the motto of the mental health care program in the country was that mental health care should be available, accessible and affordable.
Right.
So the moment you talk about availability and accessibility, that means it should be near people.
Yes.
People should not be traveling hundreds of kilometers to access mental health care. So it should be available to them within their communities, within a few a short distance from where they live, especially because many of the mental disorders are chronic and they need continuous care. So it's not just a one-time kind of consultation. Sometimes they need that kind of care. So from that point of view, it's very important to be able to establish it in the primary healthcare system. And now with the Ayushman Arogya Wellness Centers, the Ayushman Arogya Mandirs, even at the wellness centers, which is basically in the community, you have medical officers, we have health officers who are actually trained in recognizing basic symptoms of mental health disorders, improving mental health care, through yoga, through counseling, through other methods. Also to try and link up people who might need consultation for their mental health program with the NIMAHNS. And then of course there's the primary health care, the doctor, the nurse, the community health workers who are being sensitized to mental health problems, so that there is some kind of a step care model that's built up, and from the grassroots and to the apex institutions. Now, what is the role of apex institutions, which is the budget announcement, is that the apex institutions obviously provide specialized care, but it also means they have a responsibility to transfer that kind of care training and knowledge to people working at the grassroots.
Right.
So that engagement of increasing human resources, of training human resources, of hand-holding human resources, and maybe even providing a second level of counseling or a second referral to what happens in primary health care would be important responsibilities for the apex care institutions. And now with technology, that's a reality. So you can have telemedicine, you can have the primary health care doctor or nurse talking to the patient and the specialist providing the inputs to see if anything has been missed, so that the patient at the end gets a quality care, irrespective of whether they're sitting in a remote village or whether they're in an apex institution.
Right. Yeah, that's wonderfully put, actually. If we can shift gears a little bit here. As you mentioned, you worked on addiction since your student days. and addiction of both tobacco and alcohol and other substance abuse disorders. Could you help us understand and give us sort of a nationwide and region level preferences for or prevalences for what you see in your research or in your clinical care?
So one thing that used to happen at NIMHANS is that almost 80 to 90% of patients who came to us came with alcohol use disorders. And of course, alcohol is possibly the biggest substance that is used in the country, and therefore a lot of disorders emanate from alcohol use disorders. And of course, in addition with alcohol, tobacco has been something that has been very prevalent across the country. But what we're noticing in recent times is the increase, for example, in cannabis use, increase in opioid use. And while, for example, illicit opioids started off in the northeast of the country and then spread to the rest of the country, the biggest problem that we face are the prescription opioids.
Really?
So, for example, earlier we used to see things like, not so much morphine and pethidine, but propoxyphene, for example, used to be a common drug, and propoxyphene is used as a pain reducing agent. And nowadays we see a lot of tramadol, tapentadol. These are the drugs that people tend to misuse because of the psychoactive properties. So certainly there has been a shift. We've seen an increase in the use of solvents or inhalants, as we call them. People sniff glue, petrol, etc. to get a high. And many of these substances not only cause systemic damage, but they also affect the brain. So we have people who come to us either with the intoxication from these substances, the withdrawal of these substances. And another thing is, of course, that many of these substances, for example, high potency cannabis, cocaine and other drugs can also precipitate psychotic states. And therefore, you might see young people coming with a first-time psychosis where you need to look for underlying substance use. Of course, I think about 10 years ago, we did in first episode psychosis, we tried to look at underlying drug use. But apart from alcohol at that time, we did not find it. But going forward, as prevalence increases, we may need to look more and more at the underlying problem, including substance use, as precipitating psychotic states.
I see. And how specific are these gender differences about alcohol use or tobacco use or opioid use, for instance? Is there a pattern in the choice of substances that you see? You covered a little bit about regional differences, and sort of age differences possibly also exist. And I want to allude to this point a little bit. Is today's young generation having easier access to various kinds of drugs or substances in your experience?
Yeah, I mean, I think availability of substances and the affordability of substances are definitely two things that influence substance use in any population, and that's true. I mean, what you said actually struck a chord, because just, I think, day before yesterday, I was doing a presentation on looking at gender differences in substance use. And about 20 years ago, we'd only look at substance use primarily as a young male, associated with maybe a kind of personality and substance use. But now, if you look at gender differences, in every substance type, you see women's use of substances emerging. For example, you take tobacco, not as many women smoke in tobacco, it's much lower, but smokeless tobacco use is about 18% among women. Similarly, for example, the use of alcohol, and you'll see a lot of newspaper articles about young women, being intoxicated. They unfortunately make headlines, but the important underlying issue is that there are more women using alcohol. A few years ago, one of my students, quite some years ago actually, one of my students did a thesis on fetal alcohol syndrome. Basically, when pregnant women drank, what would be the effect on their fetus? We thought he'd have a hard time getting samples for his thesis. In 6 months, his data collection was complete. Which tells us that we need to be aware of these problems also being there in women. Stigma is much more in women. But the place where it's almost equal male-female distribution is the use of sedative hypnotics. So sleep medicines, the hypnotics, as we call them, the benzodiazepines,
benzodiazepines.
they're practically equally used among men as well as women. And of course, in some countries, injecting drug use, especially at a younger age, almost begins equally between girls and boys. And of course, the stigma, the consequences obviously have a gender disproportionate effect.
Right.
And that's why I think it's very, very important. Tailoring treatments and care should also be gender sensitive to cater to people with different needs. And minority communities also have higher levels of substance use, which is something that we need to be aware of.
Right. Yeah, that's pretty eye-opening in a sense. And if we look at addiction per se as a mental disorder, it's one of those disorders where the sufferer is quite judged by the immediate family, caregivers and others, and especially harshly, often ostracized in the end, and considered poor decision makers, because we always think of addiction as something one can help, right? And for the sake of our audience, if you could elaborate on the biological underpinnings of this disorder, and in very simple terms, and sort of tell us what contributes to this disorder in developing this, both environmental, genetic, if there's any contribution.
Okay, I think we need to start off, maybe I'll start off with the severe end of the spectrum, which is the addictive disorders. It's very well known that addiction runs in families.
Right.
And therefore, if there is a family history of addiction and a person starts using it socially, the likelihood of progression to addiction is much higher. So that is the genetic predisposition, the familial predisposition as well. But of course, people have to start, and that's where the environment becomes very critical. So again, availability and affordability and the kind of norms around the use of substances also determine substance use. Some people, because of their temperament, which is again perhaps a biological phenomenon, because either they're attention impaired or very sensation seeking, they're more likely to use substances. People who have difficulty in socialization and are anxious by nature, people who are extremely gregarious in their personality, risk taking, don't avoid harm when harm is in their faces. They're also at risk. It's also well known that people who tend to progress to addiction are people who do not feel the effects of the substance at lower levels of intake. So they don't have the gating or the warning mechanisms that other people might have to limit it to social levels of use and not progress to addiction.
Which might also be biological.
This is again biological. So therefore, I think, unfortunately, we have a very moral kind of gaze. We look at addiction through a moral lens. Very often, it's only in the initial phase that people might be able to exert some degree of decision making. Subsequently, it's a biological phenomenon that takes over. Substances act on the reward pathway in the brain. They become reinforcers. And once the individual becomes tolerant to the effect of the substance, the person needs to use more and more of the substance to get the same effect. And then once a person becomes dependent on it, stopping the substance causes withdrawal symptoms. And that again can be very distressing, and that maintains a cycle of addiction. That's why I think people need to really understand how important it is to make choices about the use of substances, particularly if they have a predisposition to addiction in their families.
Right. And there are some substances which have much more dependence than others, right?
Right. Actually, there is some suggestion, but then, this rapidity in which they progress to addiction is quite different. For example, nicotine possibly is one of the substances which has the greatest rapidity to dependence. Also, the route in which people use it. So, for example, injecting drug use is more likely to rapidly cause dependence because of the changes in the routes and the metabolism of the drug and its effect on the reward centers.
Right. And in many cases, addiction either leads to or manifests with other psychological conditions, probably like depression, having suicidal thoughts, mania, etc. Could you give your comments on that?
So the irony of the whole situation is that people often use alcohol or other substances to improve their low mood. And actually these are CNS depressants.
Right.
So we always say if the person is using the substance, it's likely that the substance itself is worsening the mood change.
Condition.
And it certainly should not be used as treatment, self-treatment or self-medication for an underlying mood disorder. Similarly, there are other drugs which precipitate anxiety and panic attacks. There are drugs which can cause psychosis, as I earlier mentioned. And therefore, but the important fact is that they do tend to occur together. And therefore, because the substance itself, its use or its withdrawal can also cause these symptoms, it's important to have the person free of substances, assess the person for the underlying mood or anxiety condition and treat the same. Which is why the WHO now talks of MNS conditions. It talks of mental, neurological and substance use disorders as common conditions, and substances are often known to affect brain health as much as they affect the mental health of the individual.
Yeah, indeed. And your work has also dealt with cross-generational effects of alcohol abuse, the effect of alcohol addiction on children of abusers, for instance, right? And we know that early childhood experiences do play a crucial role in the overall mental well-being of an adult. How damaging is it then to be part of such a household as a child, and what help is available to such children?
So in addition to what we talked about, the biological symptoms, the biological predisposition or the risks, the exposome is also very critical, which is the external environment. So children who grow up in households either watching violence, being subjected to violence, are subjected to any kind of trauma, also carry this as risk factors into their adulthood. And this not only occurs as a psychological phenomenon, it can also change the way the brain matures. And therefore it becomes important, especially in these high risk households, to make sure that these children in some ways are protected or supported so that they overcome the vulnerability from these kind of adverse psychosocial situations. And there are now interventions for children of people with high risks to alcohol use disorders, and this can be worse in families where both parents are using substances. In such situations, it's likely that even the normal parenting, quite apart from the adverse events that they might be exposed to, the children are not fostered in an enabling environment. If there are grandparents who take over that role, maybe some things can happen. Otherwise, the children are not able to be resilient and grow up into strong, adults. But it's also equally fascinating to see what improves resilience among children growing in these households. And that can give us important insights into what it is that we can do to make sure that children, first of all, are not exposed to such environments. And secondly, even if they are, how can they
build mental resilience
to grow out of it?
With the national treatment guidelines laid down and the regional quit line for the tobacco cessation that you were instrumental in setting up, first in southern India and then pan-India, what benefits have come off of it? And what more is there to do? I'm sure there's a lot. And secondly, we'd like to understand, what were the observations from setting up this program in Nepal, Bhutan, Sri Lanka, where you have also worked?
So I think the biggest advantage of the quit line is that it's something that people can pick up a phone and call. It helps to get access to help quicker. It's more anonymous. It's more confidential. It's less threatening to people. And that's why I think establishing various kinds of technology, whether it's tobacco quit lines, whether it's mobile cessation units, where people can just call in and get messages, can be very useful. And ideally, they should be coupled with in-person treatment and medication sometimes if people need to take medications. And we have what is called NRT, or nicotine replacement treatments, as well as non-nicotine treatments. So I think the biggest advantage has been having this opportunity for people who otherwise might never have contacted treatment services. That said, it's also very important to train people to be able to deliver these services, and that's a new skill that needs to be taught to people who run these quit lines. And again, training countries to develop the quit lines not only means training the counselors on how to talk and how to listen, but also training in the technical aspects of how to receive calls, having a structured questionnaire to ask the questions, recording the calls, following up of people, which is the same that has occurred in NIMAHNS as well. And then, of course, providing linkages to in-person services. And therefore, this kind of training in other countries which have also set up both quit lines as well as tobacco cessation facilities has been exactly that. That you need to identify good human resources, identify simple technologies which are not likely to fail.
Robust ones.
They must be simple and robust and easily available to people. And then it's likely to help people quit. And remember, these are population-based effects. So they may not, even if they're half as good or quarter as good as in person, the reach that they have is so huge that it's well worth it.
And definitely important for a country like India,
Absolutely.
where geographical differences and rural versus urban divides are so huge. I'd like to also understand from you, we discussed psychoactive substance abuse in the country. The other thing coming up is possibly social media. It's easy, personalized. There's access to influential movies and art such as we have never had in our childhood. It's very motivating on the one hand, but then it is also very debilitating, as we have realized in the recent years. Do we have a societal responsibility that we are overlooking?
You mentioned right in the beginning about young people and choices. I think the biggest conflict related to the excessive choice has been social media. Everything is at your fingertips, whether it's information, entertainment, misinformation, things that tell you about yourself, either enhance your self-image or diminish your self-image, virtual friendships, which actually have no bearing in terms of reality and how to cope with reality. I think all of these are problems, and sadly enough, I think that's the flip side of technology. I mean, we've grown so much dependent on technology. We use it in so many aspects of our day-to-day life, education, work, and so on. But it's also important to understand that excessive use of technology comes with its problems. And unfortunately, exposure to technology has started to occur at a very, very young age. And now there is information that's coming out in terms of the effects that it can have on one's cognitive development, emotional development, socialization, and so on. So I think we all have a responsibility to make sure that technology is used in a meaningful fashion, that there is no misinformation, that people are not driven to make the wrong choices, through the influence of social media. That, and that's funny, there's some very good experiments which say that even, fish, for example, the reason they swim together is because it helps to preserve them. It has so many advantages for them. And unfortunately, I think we've forgotten how important socialization and grouping is. And therefore, I think we must make sure that these kind of isolating experiences don't override that aspect of social being.
I mean, of late, many countries have banned social media for young people, for adolescents. While I do feel that might be, pushing that a bit because we are probably curbing young people's freedom, but I do feel like some measures might be needed. We don't yet know what these are because we are also a generation faced with technology for the first time in this range and in this deeply. Do you think we need measures like that, or?
I certainly think we need measures. What those measures should look like, I think we are all floundering. One of the, the approaches, Australia, for example, started it, was to ban the use of, telephones, for example, in schools and limit social media for younger people.
Yeah.
Now, looking at it, it's basically two things. One, of course, is the exertion of one's choice.
Exactly.
The second thing is how responsible can we be in providing ourselves boundaries and limits.
Yes.
And sadly enough, at the population level, or at many people perhaps don't have the ability to be able to self-regulate.
Right, right.
And therefore, I think sometimes regulations may be important, but I think we'll have to wait and see how much they help to make sure that, you know, the benefits are realized. And
because history has also told us, like with a lot of blanket bans, we've seen rebellious natures of people coming out. And
so I think it's not so much the ban, but the reduced reliance on these, and to make sure that there are other alternatives that are available to people. So for example, I think physical activity ought to be something that is necessary and available to everybody, particularly in school.
Absolutely.
So if a child does not have a place to play, friends to play with, given opportunities to kind of engage in social activities, the position, the reverting to position would be to hang around with the phone. So I think it's also about the responsibilities that adults take and society creates to make sure that young people have various fora to kind of play in, enjoy themselves in, exercise in, socialize in a safe manner. So for example, having more exercise clubs, music clubs, you know, where children can go out.
Outdoor activities
are also critical to prevent this.
And yeah, I think you already alluded to this. I was going to ask you what your message is to young students growing up now, and then what it is to researchers and clinicians as they embark on a journey through psychiatry and possibly, you know, following in your footsteps.
What I can say is that psychiatry is one of the most fascinating disciplines because it beautifully embraces medicine with the mind. And I think there's always a bidirectional relationship between the two. And to look at it through the gaze of the mind is really something that's very, very unique to any profession that people might take. And the opportunities are enormous. I mean, you could choose if you had a flair for, you know, working with people, communicating with people. Clinical work is very, very exciting. The research, of course, again is at the, you know, in some ways the best time for research because you have so many windows to look and study the mind, whether it's at the cellular level, subcellular level, or at the imaging level where, you know, you can look at big data and really understand how things work and what causes different kinds of disorders. Another exciting thing that we're understanding is that there are so many cross-cutting similarities, and many projects now are looking at that. You know, the CBM project, it also looks at the cross-cutting similarities across different diverse disorders, but also looking at why different people develop different disorders. So I think it's really a fascinating time. So I'd encourage young students, first of all, to take up biology, especially if they're in school, because I think it's fascinating to study about the brain and the mind. And of course, a career which embraces psychiatry and looks at all of these, I think is amazing. And I think there's a tremendous potential to change people's lives for the better, because a lot of, you know, things are determined by the way you look at them, your attitude to life, your attitude to decision making, to your future. And I think that's something that it's very, very enjoyable working with people to do. It's not just that they have a disorder, but to look at the individual behind that disorder and work with that individual is really a lifelong challenge, a lifelong opportunity, and a lifelong fulfillment.
Absolutely. And in closing today's episode, I'd like to appeal to the Bangalorean in you. So just want to ask you, you have inherently been a Bangalorean, have seen the city get livelier, bigger, hop onto the world map for its tech brains and startups. How has Bangalore's mental health evolved over the recent years, and what needs to be done to make our garden city possibly saner, soberer, happier?
That's a big challenge, isn't it? Yeah. So growing up in Bangalore, I always say this, that I did my entire education on one road in Bangalore.
Right.
So I, studied in the I did my nursery in the home science institution, I remember fantastic memories of being fed upma, which I've grown to like, as well as I think it was jelly by the students of the home science college. And then of course, after a small break, I went to Sapphire's down Palace Road, then Mount Carmel's, and then backwards across Avenue Road to Bangalore Medical College, and then NIMAHNS not too far away from there. So I think Bangalore was a very comfortable city. It was a walking city, it was a cycling city, it was full of greenery.
Yeah.
I certainly have seen that reduce. It's become a much more vibrant, much less sleepier city.
Yeah.
It's got lots of things going for it, lots of socialization, lots of, opportunities to meet people, etc. Lots of technology happening in Bangalore.
Right.
So that's, I think, all the positive side. And of course, huge educational and employment opportunities.
Right.
But I think big cities also make us feel lonelier. So I think the challenge to Bangalore is to make itself a mentally friendly city, to have more natural, spaces available to people, to have safe spaces available to people, and of course, to have good policies around substance use, because I think the biggest thing is the availability of substances very easily to people. And of course, now we talk about safe and smart cities, which also address the mental health needs of people, which is looking at the congestion, the noise pollution, the safe spaces for women, for example, to be out in. I think all of that are good, important contributions. It's a lovely city still. It's my city. It's Nama Bengaluru. We're very proud of the city. And we, of course, also constantly need to see how we can make it better while it's getting bigger.
Right. With that, I'd like to thank you for being on this episode of the podcast with Bate. Thanks a lot, Pratima, and we'll catch up with you about a different topic, which is the National Mental Health Survey too.
Thank you, Shreya. Thank you for having me.